Great. Thank you for the introduction. Let's see how this works. There we go. So clinical motivation. So as many folks know, hypoxic regions have been shown to be radioresistant and also correlate to more aggressive phenotypes of cancer. So some folks have started investigating monitoring hypoxia to predict treatment response. Now we can't image hypoxia directly with photoacoustic imaging, but we can image oxygen saturation, which is related to hypoxia. So oxygen saturation is going to give you what you see in the vasculature. Hypoxia, though, is concerned actually with partial pressure of oxygen right outside the vasculature, so in the intercellular space. But they tend to be correlated. So the question is, can we use oxygen saturation as a surrogate for that? So the application we're going to be talking about today is tracking therapy quantitatively. So we actually used a HCC model in rat to track sorafenib, which is one of the few treatments for HCC. So the mechanism is still not precisely known. So in this initial pilot study, that's what we're sort of working on, is preclinical, trying to figure out, better understand that mechanism. However, many patients show adverse side effects to this treatment. So in the future, if you could predict treatment response so that they weren't responding, you could get them off the treatment regimen, there could be value there. And the treatment affects the vascularity of the tumor, so we're going to look at perfusion, so ultrasound-based perfusion, and oxygen saturation. So clinical need, imaging method to better understand, and this is really from the preclinical realm, which is what we're going to limit today, but then down the road, hopefully, to monitor, predict, for clinical aspect, treatment response to this drug. So I won't really go into photoacoustic imaging because other folks have already presented on that today, but in this study, we're really leveraging multi-wavelength imaging, which allows you to characterize a chromophore. So we're going to actually do 2 wavelength imaging, but you can use more than 2 wavelengths to characterize endogenous or exogenous chromophores. And in this case, we're going to be characterizing oxy to oxy plus deoxy, so the oxygen saturation of the tissue. And with photoacoustic imaging, we can concurrently do that. In addition, with ultrasound-based perfusion, harmonic imaging, we can assess perfusion. So study goals, photoacoustic oxygen saturation monitoring, intertumoral changes in an in vivo rat model of orthotopic HCC. We're going to monitor response to sorafenib, which is a kinase inhibitor approved for use on HCC, and then correlate those data to ultrasound perfusion data as well as to histology, H&E for the time being. So we used our Vevo laser 2100 system, which is really intended for mice imaging, and that's what we've been doing the last few years. In this particular application, though, we used a lower frequency probe, and I'll show you more about that in a second, a 15 megahertz probe to try and probe deeper into the rat. It has a tuning range of 680 to 970, nominally about 20 millijoules, so significantly more energy than the last talk, but really low rep rate. 3D imaging with elevational translational imaging, and you can achieve concurrent B mode, Doppler, and contrast imaging, and we use micromarker microbubbles for our nonlinear contrast imaging. Now, a rat model. The reason we chose this, I'll get that in a second, is it's really a lot more clinically relevant as concerned by interventional radiologists. So it was an orthotopic model, so directly into the liver. The rats were huge, so they were almost half a kilo, which presented a number of problems. I'll get into some of those in a second. Tumor size we tried to keep between about 7 millimeters to 12 millimeters in one aspect. In the other aspect, they actually got much larger than that. Now the benefits, orthotopic versus subcutaneous, a lot of folks think that the vasculature is more clinically realistic. It's intermingled with the liver. Now specifically rat, the neat thing with a rat is you can actually perform an embolization. So a lot of interventional radiologists are particularly interested in that model for therapy because they see it being a lot more clinically relevant. When I first started discussing this, though, I was sort of concerned because obviously the imaging depths are a lot more significant than what you see in a mouse. So tumors are quite deep, and the tumors themselves are quite large. So to try and address this issue, we used a new probe that actually Drew Heimiller at Visual Sonics developed. It's a 15 megahertz, their rat platform, but with a concentrated fiber bundle. So it's actually got the same fluence, the same number of fibers as their typical array, but they're all concentrated here in the center. And what you see is then the photoacoustic signal is actually just relegated really to the sort of center third of the image. What this allows us to do is we can actually get reasonable signal at depth. which was obviously our goal. And then coupled with that, we then used a standoff, which turned out to be sort of the game changer, because through this near field absorption, we get really bad reverb. And so this reverb artifact would often confound our imaging at the tumor site, so we could push the skin down at a fixed distance from the transducer face to try and mitigate that effect. So experimental parameters, we imaged 7 rats. Unfortunately, we had an issue with 5 of them, though, and I'll go into it in a second. Sorafenib was administered on all of them. We had a pre-treatment imaging protocol, 7 days post-treatment, and then 14 days post-treatment. I'll present 2 rats today. Those were actually the only 2 that survived through the course of treatment and that had tumors that could be imaged. 2 died during treatment, and 3 had tumors that actually grew deep to the liver, which is something that we were sort of at the time tweaking our inoculation protocol. So we're trying to remedy that now. Our imaging protocol, we used just 2 wavelength because we did volumetric imaging, so we wanted to be somewhat quick. 3D photoacoustic imaging under both oxygen and then pure medical air, or medical air rather, so about 20% oxygen. And then following that protocol, 150 microliter bolus injection of microbubbles to assess perfusion, so the wash-in, wash-out just at the tumor midsection. So it's tumor segmentation, that also tended to be a bit difficult. We didn't get really nice contrast in our B mode. The lateral aspect really was not visible. And so what we noticed is in the MIP, we could see the vasculature quite nicely, and so it allowed for easier segmentation by the interventional radiologist. So we used our MIP imaging for segmentation. So some of the preliminary results. So these are photoacoustic oxygen saturation maps of the near field and then of the tumor. The tumor is outlined in green. And we have on the left the pre-treatment and on the right the post-treatment. The first thing you'll notice, in the top is medical air, the bottom is oxygen. So the first thing is in the near field, we saw what we expected. You see an increase, so red is more oxygen saturated, blue would be less oxygen saturated. So we see an increase with increase in systemic oxygen. However, the tumor site, we don't see much of a difference, and I'll get more into that in a second. In post-treatment, though, we see an increase from medical air to oxygen in the proximal region, and then we see a similar increase at the tumor site. And we actually saw this between both rats at all treatment time points, where we didn't see much of a difference pre-treatment at the tumor site between the 2 conditions, medical air and oxygen, but we saw a much greater difference post-treatment at that site. So an increase in med air to oxygen SO2 difference, and there was no real clear correlation between absolute SO2. So we were expecting that we might see a difference in absolute SO2 longitudinally. That was, at this point, again, very few numbers right now. We have not seen any readily apparent correlation there. Pre and post-treatment perfusion, so we actually saw an increase, this was somewhat counterintuitive, an increase in perfusion. So this is pre-treatment, and I showed 2 wash-in metrics, time to peak and wash-in rate. And so our time to peak is longer pre-treatment and then goes shorter post-treatment. Wash-in rate increases post-treatment. So indicating that the perfusion actually, and you could actually see this, it was quite apparent on the nonlinear image that they appeared to get more perfused, at least in this very limited 2 rat cohort. And so here we saw that across all the time points where we see time to peak decrease and wash-in rate increase. And now, so this is probably the most interesting, was correlating or trying to start correlating the oxygen saturation to perfusion. You would expect them to be correlated, and this is often, although not always, what we saw. But these are representative images of often what we saw, which was, here's wash-in rate, so you have your tumor right here, so higher wash-in rate would be correlated to greater perfusion. In the more poorly perfused region, we actually saw decreased oxygen saturation. In the more greatly perfused region, we saw increased oxygen saturation. Here's another example of that. Here's another rat with 2 regions of increased oxygen saturation, increased perfusion, decreased oxygen saturation, and decreased perfusion. And here's a third example where we actually see increased oxygen saturation, increased perfusion, a significant decrease, and then something in between. And lastly, trying to correlate to histology, which in this model has proved to be particularly difficult. We had done it previously with subcutaneous models. This one the tumor is so large and it's so deep that by the time you harvest, it's very difficult to co-register. But in this particular example that we were able to co-register, we can see this is with a MIP, so you can see a reduction in the perfusion, or in the signal, and that actually correlates to a reduction in photoacoustic signal, which is sort of a problem with a lot of these techniques, is what happens if you just can't get, if you're trying to assess oxygen saturation and you can't get in a poorly perfused organ signal at all, what can you tell from that? So we're trying to figure out a correlation between perfusion and lack of photoacoustic signal. So this is sort of first steps in that, and we see confirmed in H&E histology that you have an avascular region, that part of the tumor. So in conclusion, it's possible we were able to obtain PA imaging data on many, although not all, of the HCC tumors, rat tumors, spelling. Perfusion-based metrics correlated to therapy progression. This is counter to what we expected. Perhaps it improves vascular regularization, so you're getting greater perfusion. SO2 variation, so medical air versus oxygen, correlated to therapy progression. However, we suspect that might be an artifact of that near-field absorption, that we could be getting an effect of clutter at the tumor site. Additionally, that near-field absorption changed through the course of therapy, so wavelength dependence on those two different transmits, 750 and 850, could be confounding what we see at the tumor site, given that it's at such great depth. Reduced perfusion correlated with, spatially with SO2, low perfusion agreed with low vascularity. So future work, obviously increase the sample size. We're starting to image the tumors when they're smaller, so hopefully they can survive the treatment. We're also optimizing the inoculation site so that it can grow more proximal to the transducer and not deep into the liver. And most importantly, I think we're pursuing phantom validation, which we probably should have done initially, at depth. I think there's a problem when you try and apply some of these oxygen saturation estimation methods at depth, where you have clutter, you have a wavelength-dependent attenuation. So we're doing this now in a phantom where we can adjust the scattering, we can add a near-field absorber, and also doing this at more than 2 wavelengths. And here's the phantom down below, and then correlating to pimonidazole stained images. Knowledge funding sources and other collaborators, and thank you for your time.